This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I am Mariana Parks, physical therapist and your host, and today I'll be interviewing Eva Silvestre to discuss the diagnosis of neuropathic pain and its presence in diabetes. Eva is a postdoctoral researcher in the Neuromusculoskeletal Health and Science Lab, supervised by Prof Annina Schmid. In our discussion today, you are going to learn about neuropathy and neuropathic pain, the grading system used to diagnose neuropathy, and how to identify peripheral neuropathic pain in diabetic patients, and how to manage it. So if that sounds interesting to you, I encourage you to subscribe to our channel, click on the bell to stay updated, give us a thumbs up, and share with other clinicians if you might benefit from this conversation. Thank you for tuning in, and I hope you enjoy the show. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like
Fitter First, your first choice for the best Canadian-made rehab and fitness products since 1985.
Hi Eva, welcome to PT Pro Talk. How are you today?
Hi Mariana, how are you? Thank you very much for having me here today. I'm good. And you?
Awesome. Yes, everything's going well. So let's start talking a little bit about yourself. So tell us about your background and your career and all the things you've done so far.
Thank you for the question. Well, I'm a physical therapist. I did my undergrads and my master's back in Spain, where I'm from. And then I decided to continue for a Ph.D. And the reason to do that was because in the clinic, I was seeing patients that I couldn't explain what they were having, right? Like this kind of pain and neuropathic pain, which is finally what I decided to pursue. So I thought like there are some questions for which I need some answers, and who else is going to do this? Maybe it could be myself. So that's when I decided to do a PhD, and it was a long process, but in the end, I did a PhD between Australia and the Netherlands, and I finished September last year. And since then, I'm working as a postdoctoral researcher with here at Oxford at the Nuffield Center for Clinical Neurosciences with Annina Schmid. And I'm continue working on neuropathic pain and neuropathies, which is what I really like, trying to understand the mechanisms of action of some of the treatments that we do in physical therapy. And that would be more or less my career in a few sentences.
Awesome. And so since you're going to talk about pain, let's just start with the definition of the different types of pain, so it makes more clear about what we're going to talk about next.
Okay. So for those of you who are not that familiar with neuropathies and pain, I think it's important that we make a first distinction. So neuropathies by itself is any disturbance of function or pathological change that occur in a nerve. And those neuropathies may be painful or non-painful. And I think this is important because sometimes people associate neuropathies with pain, and it's not always the case. And I'm going to bring here a topic that we may talk about this later, which is diabetic neuropathies. And I guess everyone is familiar with people having diabetes and having these ulcers in their feet, saying that they are not painful, right? Well, this is an example of a neuropathy that is non-painful. But if we go back into pain, and I already gave a hint on this, we could classify pain into three groups, or that's what we say nowadays. So we have this nociceptive pain, where we are all familiar with. So for this type of pain to happen, we need a lesion or some damage. We hit our hand, and then our nociceptors detect this kind of stimulus that is transformed and transduct and interpret in our brain, and we realize, okay, this is pain. And then we have neuropathic pain, which may be not so familiar for some people. And in this case, this one is classified as pain that is caused by a lesion or a disease of the somatosensory nervous system. So in this case, we don't need to hit or we don't need to activate our nociceptors to have pain. And I think it's also important to know here that it can also be a disease, the one that is causing this neuropathic pain. And again, I'm going to bring back diabetes because that's the topic that I work on my Ph.D. And then we have another type of pain that is a bit, some people are in favor of it. Some people have some, some different opinions on that, but it has been defined as nociplastic pain. And this one is pain that arises from altered nociception, but there is no clear evidence, or we cannot find nowadays any signs of tissue damage that may cause this activation of these nociceptors. So this would be these three different types of pain that are defined at the moment. And it's also important to know that these ones are not exclusive. It may be that a patient presents with neuropathic pain and nociceptive pain as well in different areas, right? Like it can be the case. So depending on what is the cause behind it, right? If we see that, what is the lesion? If there is any lesion, if there is anything that can explain that pain, and we can classify it in one of these different groups.
Yeah, and I think that's when it becomes confusing because it could be a lot of things presenting at the same time, and then we have a hard time differentiating those. So that's another one of the things that we want to talk today about. So how do you diagnose neuropathy? And I saw like in some of other papers some grading systems, so like being possible, probable, and all of that. So would you tell us a little bit about how do you diagnose neuropathy?
Sure. So I think the most important part, like with any patient, right, is clinical history and listening and realizing what is the patient telling you, right? So for nociceptive pain, usually there is an issue, there is, an ankle sprain, and we can easily kind of identify where is this pain coming from. When we think about neuropathic pain, there are some requisites that we need to follow. And actually, as you were rightly saying before, there is a paper published and they summarize all of these into a grading system for neuropathic pain. And I think this is quite interesting. And I would refer people to read this paper. We can maybe provide the link later if that's okay.
Uh-huh.
So with this system, I think it's very important to understand the first thing that we may encounter in the clinic is someone that is complaining about pain. And then we need to decide, okay, what type of pain we are facing in this situation. Because depending on the mechanisms of pain, we will approach therapeutically different, right? We need to understand what's going on, because once we have the right diagnosis, we can apply the right treatment. Otherwise, it's going to be very complicated to go with this.
Absolutely.
So, right? Yeah. We have someone that comes and, has pain, and then we need to ask, as we do always, okay, tell me about your history. Is there any, we need to understand, is there any relevant lesion or disease that can explain the situation that we are facing? And it's also very important as well, even though not always matches, but to understand the pain distribution and whether it's neuroanatomically plausible. It is important also to know that when we think, for example, about entrapment neuropathies, for example, if we think about carpal tunnel syndrome, we typically have in this idea this distribution of pain in these three fingers. But we know nowadays that we may have patients that have different distribution of pain, and it can also be carpal tunnel syndrome. If we think about radiculopathies, we always think about, this pain that comes from the buttocks to the foot. But there are other presentations that are not typical that can also be a cause of neuropathic pain. So even though, we may find these situations, it's important to map all these distributions of pain and trying to make the big picture on this. So if none of these ones make any sense, there is no history. Like I was saying, for example, if we think about an ankle sprain, and then the distribution of pain, the history, there is no lesion behind it, and then neuroatomically distribution of pain, well, it may be that is not the case. So it would be very unlikely that we are facing a neuropathic pain. So this would be our first level. And then if these two matches, and if this too much, then we will think, okay, this could be a possible neuropathic pain. So the next thing that we have to do is to try to prove or, try to understand whether we can move on into being more certain about facing someone who has neuropathic pain. So the next thing that we will do would be a neurological examination. And we will try to find either sensory signs in this patient that may explain this presentation in this neuroatomically plausible distribution. So when I'm talking about sensory signs, these are things that we are familiar with, like, for example, checking the sensation, like we've done before with cotton wool, with pinprick, trying to find these signs of sensory loss, muscle strength test to check whether there is any weakness, reflexes. All these things are going to tell us whether there's a sign of sensory loss that could be associated, in this case, with neuropathic pain. So if that's the case, and then we find these sensory signs, then we will move on in our certainty range, and this would be a probable neuropathic pain. And then if we are lucky and we have the resources and it's necessary, because it's not always necessary to have a confirmation of a definite neuropathic pain to be able to treat it. But if this is the case, then we can run diagnostic confirmatory tests to confirm that this lesion or disease could be the responsible, in this case, to explain the pain. And this would be, for example, nerve conduction studies. It could be all these kind of tests that are a bit more advanced, like biopsies of the skin, corneal confocal microscopy. All of these ones are tests that could be the confirmatory tests that we need for someone who presents with pain to say this is a definite neuropathic pain. So this would be more or less kind of this grading system, as I said, for neuropathic pain. And that would be a logical approach in the clinic when we have someone who presents with pain, and we think like the history and the distribution of symptoms may be in this line.
Yeah, so you go through those steps, and then ideally, if you had all the 3 steps, then you would know for sure that it is. And if you can do like a diagnostic exam, do you feel like would it be sufficient the step 1 and 2, like the history and then the neurologic exam?
Yeah, that's a very good question. So usually in the clinic, we lack some of these resources, right? When we're talking about, for example, nerve conduction studies or skin biopsies. And as I said, it's not necessary. It's not going to change the approach we're going to have. Usually, we use these confirmatory tests when we are not so sure, and, it looks like it could be neuropathic pain, but it's not, or it could be more like neuropathic pain from a genetic disease, conditions like this that may require further investigations. But as I said, if we have our probable diagnostic PhD there, that's good enough to start with the treatment, even with pharmacological management. So that's for clinicians out there to to realize that it is good enough after there.
So since you just mentioned about treatment, I'm gonna jump to treatment. So like, how do you feel that's clinically important to differentiate these types of pains in regards to the treatment, and how you do approach those types of pain?
Yeah. Well, that's a very good question, and I guess like all of us that work with neuropathic pain would wish to have like the ideal treatment to manage these patients, because it's important also to realize that these people usually suffer with more depression, more anxiety, poor quality of life, and, more problems at work, all these things just because of having this neuropathic pain. So it is really, really important to find a good way of managing it. So when we talk about nociceptive pain, I'm not going to focus too much on that because I guess this is the pain we are more familiar with, and we have our strategies, right? So if we are talking about inflammation, it's as a mechanism of nociceptive pain, we know how to treat it. But in the same way, when we are talking about neuropathic pain, we need to understand what kind of mechanism is behind this, or in pain in general. Let's put it in pain in general, right? It's going to be easier that way. So if we think that is more nociceptive, then we know our techniques and we know how to manage it. If we are thinking about pain, for example, that is more neuropathic, then usually there are medications that can help. And again, I can provide you with another link if people want to look into this, because, it's very specific. And as a physio, there are other people that are more prepared to approach this, but I think it's important to know. And there are some aspects of neuropathic pain that we can manage. And for example, we know that aerobic exercise is good in some conditions that present with neuropathic pain, especially, for example, if we talk about entrapment neuropathies. So in these conditions, we know that exercise can provide this influx of oxygen, and improve the condition and the symptoms. And to be honest, it's really important to know how to manage it, right? If we think also about entrapment neuropathies or conditions like carpal tunnel syndrome, for example, we can also explore these neurodynamic tests as well, because sometimes it may be that within this condition that we have, there are other aspects that may be influencing the pain that patients are presenting with. So it could be that the nerve is also mechanically sensitive, and we can try to improve the neurodynamics in this case. And if we test with these neurodynamic tests and we see that is positive, this could be a technique that we can introduce in our treatment with patients with this condition, for example.
Well, then. And would you give us a few examples of neuropathic pain? Because I think it's going to be easier maybe to talk about treatment when we define the different types. Like, I think we in the clinic, at least in like outpatient setting, we are more used to like radiculopathy. I don't even know how to say it. So you have like a bulging disc pinching on the nerve, and you have that pain radiating. So those are the types of pain, at least that I am more used to treating. And we have techniques and things to treat that type of pain mechanically. As you mentioned before, we have a few options there. But there are a lot of other types of pains that neuropathic pain that I think it's a little bit more difficult to manage. Would you talk about those types of pains and if you have any suggestions there?
Sure. I don't like giving suggestions because I think every patient is different. And as I said, I think it's really important to understand the mechanisms behind it. So if we realize that our patient presents with a pain that is more driven by inflammation, then we know the techniques that we can use for inflammation to treat that. And if there is a pain that is more driven because of an entrapment, for example, and there is an interface that is increasing or contributing to the pain of our patient, and we test for that, and this is the case, we know how to treat it. And depending on the condition, you may have different mechanisms behind the pain. But some examples, in general, we can classify neuropathic pain, for example, in periphery neuropathic pain or central neuropathic pain. So from periphery, we can talk about these entrapment neuropathies, as you mentioned before. And there are examples like these carpal tunnel syndrome, radiculopathies. Those are examples of entrapment neuropathies. We can talk about distal symmetrical polyneuropathy, which is common in people with diabetes, for example, and this is also kind of periphery. And if we think about central neuropathic pain, people that work with patients or people who had a stroke, they may have also pain after that. Or if they had a spinal cord injury, some of these people may present as well with central neuropathic pain. So these are some examples of conditions that could present with neuropathic pain.
And I think talking about more the central neuropathic pain, I am not familiar with neuro. Last time I saw it was probably 12 years ago when I was in college. Do you have a specific way to treating that type of pain? Like, can we do something as PTs to help on that pain?
Again, I'm not a neuro physio. I haven't worked with these patients. I'm more focused in peripheral neuropathic pain. But
yeah,
again, if we think about the mechanisms of pain that could explain the presentation that these patients are having, I'm sure there are papers out there, and our fellows neurophysios maybe
we have to find some neurophysicists to come here and talk about
someone here on the podcast to enlighten us.
Yeah. Because that's the thing. Like periphery pain, I am more familiar with. I was like, well, I was reading that paper that you sent me, like all those like central pains, and I was like, well, I don't know about those. I'll have to get someone here to talk about that. And about diabetes that you were talking about there, neuropathy pain. Is there a way to treat that type of pain that is caused more systemically versus like just, we know, like a nerve root being compressed by the disc, we know we're used to that. Is there anything that we can do as clinicians to help those patients?
So this is it's a topic that I'm fascinated about because it was one of the questions that I had for my PhD because it came from the clinic. I remember treating a patient in the clinic who had pain in her hands, and, it was excruciating, and she was even wearing gloves in summer in Spain, which is not very common. And I was like wondering, okay, what is she having? It was very common in the tip of the fingers, but she was having this pain, but she couldn't feel very well. So I had this question, and I started to look into this, and that's when I came up with the literature, and then I realized that people with diabetes can develop these neuropathies, and it was a neuropathy that I hadn't studied before back in my degree. So it's a condition that usually starts distally from the toes of your feet, and then it can progress over your feet and even below your knee. And over time, it may also reach the hands. So this condition is quite funny because we don't know why some people have pain and some other people don't. It's also different in people who present with type 1 diabetes and type 2 diabetes in a sense that the mechanisms behind them are different. And I find it exciting in a way, like as a researcher, to have these years ahead of me, fingers crossed, to continue investigating on this and trying to understand why some people have pain and some others don't. And the way we treat these patients in the clinic, well, actually, it's quite challenging because with the feet, I guess we are all more aware, right? To tell people to check their feet for any ulcers. But I think it's important as well to keep these people active. We know that exercise can improve the symptoms that they have. And it's also a kind of physiotherapy that is more about integrating also with other colleagues, with nutrition, with psychology, and to bring this all together to improve the health of these patients. But for example, as I was saying before, aerobic exercise, it can be an option to treat this. And if you ask me what is best, I have to tell you that we don't know yet, because one of the challenges as well with people with diabetes is also to, it's a condition that is forever, is chronic. And one of the important things to control your symptoms with neuropathies as well is to manage very well your levels of glycemia. So yeah, in some people, they're better at doing this, some others are worse, and the same with the adherence with exercise. So it's challenging to recruit people and trying to make them understand how important exercise can be and keep them on track with that to check results after that. And yeah, it would be lovely to do this. There are some studies out there, but yeah, I think we still need to do some more on this.
And how would you define the neuropathic pain, like in the context of diabetes? Like, how is that, how it happens?
Yeah, we don't know. Again, and I'm sorry to give you this answer because, the first one that finds out, it's going to be a Nobel Prize or something. But at the beginning, I was not so sure whether there were two separate conditions, like either you were non-painful diabetic neuropathy or distal symmetrical polyneuropathy and painful distal symmetrical polyneuropathy. It seems that these distinctions with like everything in life is not so clear, and it's more like you can go from one to another depending on how well, for example, you are managing your condition. It can be one of the reasons for that. So yeah, we don't know why some people develop this pain and some others don't. Yeah, I can also provide you with another paper that I think is quite interesting, revising all these concepts.
Yeah. And how do you diagnose that? Is there like a system or like something that you use to help diagnose those pains?
Yeah, so the system would be for the diagnosis of diabetes and distal symmetrical polyneuropathy. It will be again following this grading system for neuropathic pain. So in this case, there was also an update of this classification, or a more specific one for distal symmetrical polyneuropathy, which was published in 2010. But again, it will be very similar. We are looking for a clinical presentation with a neuroanatomical distribution of symptoms. That it could be tingling, numbness, it could be pain, depending on which type of fiber is affected in this condition. And usually, as I said, the typical presentation would be starting from the toes and progressing to the feet, lower legs, and then hands. But there are also atypical presentations. So the one that is more common, as I said, and most of the patients with diabetes would have, is this bilateral presentation. So both feet are affected, and over time it could be that also both hands are affected. So this would be the most common one. And then again, we would do our neurological exam and check, map this sensation that they have in their hands, whether there is a lack of sensation to the cotton wool that we may use in the clinic, check the strength. There are also some specific tools that we can use specifically for diabetes and distal symmetrical polyneuropathy, which is a 10-gram monofilament. And this one will give us an idea as well whether there is a loss of sensation of the foot, which would be a sign of neuropathy. And it's also a good indicator or a predictor of developing an ulcer in 5 years if they are not able to sense it. So I think it's quite a cheap tool to have in the clinic and to check in our patients with diabetes at least once a year or every 6 months, depending on how severe the condition is, just to have a bit of an understanding on how the presentation is going. And then after, again, our neurological exam, which would be probable, for example, neuropathic pain, if we found these signs of neuropathy, then typically, again, in this condition, we stop there. We don't go any further with the confirmation of this diagnosis. But it may be that for some presentations that are not typical, some people may go into a nerve conduction study or a skin biopsy of the leg just to check whether there is a loss of nerve fibers.
And like sometimes in the clinic, I've had a few patients like that they have diabetes and they have lower back pain and they have neurological symptoms, and then you're not sure if it's coming from the back their back pain or if it's the neuropathy from the diabetes. Um, do you have any tips? I know you mentioned that sometimes they are bilateral. Um, Anything like it's more the history of presentation, maybe when they start having the symptoms, if it's the same time as they diagnose the diabetes. So like how do you have any tips to help us differentiate if in that moment is maybe the neuropathy of the diabetes that's progressing or if it's the lower back pain that's presenting those neurological symptoms?
Yeah, that's a very good question. So if we think about this presentation of distal symmetrical polyneuropathy, as I said, it's typically feet and lower legs, sometimes a bit of upper leg, but it's distal, and it never reaches the back. But we can, as I said, the most important thing here is listening to your patients. And you can also pay attention to the descriptors that they are using for pain, right? If they say that it's burning, if they say that it's tingling, aching, drilling, all of these ones are more into a neuropathic pain kind of aspects. But if it's more like throbbing, those is more like blood flow related, or if it's more like stabbing, depending on the descriptors that they use for pain, that can also help. And as I said before, neuropathic and nociceptive pain can coexist. So it may be that we have a patient who presents with this distal symmetrical polyneuropathy, which we know that is a patient that has a lack of sensation in their feet, and at this moment comes to the clinic because he has back pain. And then we ask, and then there are positions, for example, that can ease the pain, and some positions that can aggravate the pain. And there is, for example, the descriptors of pain, whether it's a deep or a superficial pain, or it's more, like stabbing pain, things like this, or electric shock. Depending on these presentations, we can think of, okay, maybe my patient who has neuropathic pain in their feet because of his diabetes is now presenting with nociceptive pain because he was working in the garden and then, something happened. So I think it's really important to listen to our patients and let them explain what they have to say and dig a bit more about how is pain behaving during the day. Is it more common at night, for example? We know that usually, specifically in neuropathies, are more acute at night, and people struggle with sleeping, also with neuropathic pain. Understanding whether there is some positions that can ease or aggravate the pain, that's mechanical. And that's also a window for us for treatment, right? If there are positions that can ease the pain, then we can use those as a way of treatment. So again, it's more about adding a new layer into our screening for these patients to consider this neuropathic pain whenever we think that there is a history and there is a neuroanatomically plausible distribution of pain that can explain the situation that we are looking for. And it's as easy as going through our neurological examination, quite quick, and, trying to find out whether it could be, neuropathic pain or not.
Yeah. And some of those patients that I seen, so like they have like distal pain, and then like I use a lot of the McKenzie method that we try to centralize the pain. So it should move from the feet towards the back. And then in some patients, the pain is not going to move because it's caused by diabetes. So that's another thing that I feel like we have to pay attention because we are expecting to see that pain changing and it doesn't change and it doesn't change. And then I think that's when it's important to pay attention to see if that pain is something that we can change with treatment, if it is that nerve distribution coming from the back, or if it's just something that is going to stay there. Because how is the prognosis of someone that has distal pain with diabetes? Like it's just, you just control with medication? Like, do you see that improving, or is just over time it's just going to get worse and there is not much that we can do?
Yeah. So I've seen, going back to your question about McKenzie, again, I guess if we are talking about a pain that responds to mechanical load, then you will see a change. But if this is not the case, then maybe that explains what you are seeing there. And then if we think about the prognosis of pain in neuropathies, well, think about this. Once you have diabetes, it's going to be forever with you, right? At the moment, we don't have a cure for that unless, your condition goes really, really bad managed, and then over time you get a transplant, pancreas transplant, and then something changes. But diabetes is going to continue affecting all your organs in your body. It's not only the nerves. We know that people have issues with their eyes, many things, heart, with I forgot the name now, but all your organs in your body. So the prognosis in this case is trying to manage as the best we can our levels of glucose over time, especially in type 2 diabetes, because we know that this is a risk factor for developing distal symmetrical polyneuropathy. It's not very clear whether it's linked to development of pain, but we know that at least for preventing these neuropathies, if we have a good control of our glucose levels, that will delay or maybe not even develop this condition. So that's one of those. And then there is medication as well for this. But with all this neuropathic pain, some of the medication that we have is not actually resolving the issue. For some people it does, and it can happen that they can manage their condition with the medication, but you may find a lot of people that this is not the case. So I think it's very important, the education that we do to our patients, like telling them how to control their glucose levels and how to find other ways to control that, like exercise again. So trying to be active and, trying to promote aerobic exercise, because that's going to also improve the health of any tissue in your body, but also the nerve. So I think this is key here as well.
Mm-hmm. Awesome. Eva, anything else before we wrap up to the final questions? Because I know we went all over the place to talk about neuropathy, pain, diabetes, like anything else that you think it's important to mention before we go to the final questions?
I think I would like to raise awareness on the presence of neuropathic pain and how to take this into account in the clinic. And as I was saying, it's important to go through our history taken, listen to the patient, and incorporate. Never forget about neurological exam, because I know we learn it back in school, and then later on, unless you're a neuro physio, then you may forget about it. But in this case, I think it's really important, if we're working with people who have pain, to incorporate it in it, because as I said, we're not going to treat the same someone who presents with a loss of function in their nerves, someone who presents with a gain of function. The approach is going to be different. So this is important to remember.
Review the neurologic exam. And Eva, what is your favorite resource of information? Anything in particular that you like and recommend the audience?
Well, as a researcher, I guess it would be PubMed, and probably you've got this answer already. But I guess that would be my source of information. Trying to be up to date with publications and creating alerts on anything on neuropathic pain.
And what would be the best advice that you can give to clinicians that are starting their careers?
This is a very nice question to ask. I think is to not be afraid to invest time in your history taking. I think, like, if you're given 30 minutes per patient, it seems sometimes that you need to do something before the patient goes. And, you go maybe 5 minutes asking the very basic questions, and then you have to do something, right? But over time, I think that was me as well at the very beginning. I'm like, okay, a few questions, and then I get going. And then I realized this is not clinical reasoning, and clinical reasoning is the most important part, understanding what the patient brings and listening to the story, because if you let patients talk, that's going to give you the key on how to focus, your clinical reasoning and your treatment. And in the end, you will save time. So I feel like it's more productive in that way, and it's going to be more beneficial for the patient and even for you on your treatment, because you're going to go more into the real, trying to find the real cause of the situation you're facing here.
Yeah. And address what they wanted to be addressed, because sometimes what you think it's important is not important for them. So
that's true.
Try to see what they want out of that. I think it's important.
How can I help you today?
Yes, exactly.
How can I help you? I think that's really important question to ask.
Yeah. And what personal qualities or abilities that you think are important to become a successful PT?
Well, if we go back to what I was saying, I think it would be active listening. And I would say also, try to analyze your own treatment and your own reasoning, right? Trying to think about, okay, I've treated this person, I had this patient. Would there be any other options? Am I missing something? And I think that also brings you like more richness into your reasoning. And I think it's also a process of becoming more senior as well. So I think that reflection on your own practice and active listening and, keeping up to date with the literature, I think those would be the 3 pillars that I find are more important.
Awesome. Eva, if anyone wants to learn more about you or contact you, see your research, how they can find you?
Well, I'm on Twitter, even though I'm not very active lately, but I can give you the handle later. And then I'm also on LinkedIn if they want to reach out there. I have a webpage where I try to upload recent papers or, this podcast once it's ready, these kind of publications. And as I said, at the moment, I'm here at the University of Oxford. So if anyone is around or visiting, I'm always happy to be there and have a chat. And, it's always interesting to meet people from everywhere and their experiences.
Awesome. I appreciate so much you taking the time to come here and share your knowledge with us. So thank you so much.
Thank you for inviting me. It was a pleasure, Mariana. Thank you.